Now, that is something that's commonly encountered in our day-to-day practice. The topic will be presented by Dr. Nishana, who is a DNB resident family medicine, Lourdes Hospital. And today we have with us Dr. Emil J. Tachil, consultant rheumatologist at Lourdes Hospital, who will be actually chairing the session. Dr. Emil graduated from Government Medical College, Thrissur in 2001, took his MD in General Medicine from GMC Calgary in 2007. And then he went to pursue DNB rheumatology in Nizam Institute of Medical Science, Palakkad. He was a consultant rheumatologist in various reputed hospitals in Cochin and Thrissur. He has published many articles on rheumatoid arthritis, Takayasu's arthritis, and so on. So on behalf of Spicewood Kerala, once again, I would like to welcome Sir to his session. And also I would like to welcome Dr. Nadeem, State Lead for Spicewood Kerala. Welcome all once again. Over to Dr. Nishana.
Good evening all. As general practitioners, we have to encounter a common complaint, that is joint pain. Patient will be coming with us with the complaint of joint pain. Here I am going to discuss the approach to arthritis. How can we deal with joint pain, and what are the self-limiting minor elements, and when we should refer the patient, or when immediate diagnosis of emergencies are needed. Can I share the slides?
Yes, you can share the slides.
Host is disabling slide sharing. I can't share.
Okay. Now you can share.
Okay. So coming to approach to arthritis, when a patient comes to us with a musculoskeletal pain, first we have to identify whether it is pertaining to joint, that is articular, or surrounding tissues are involved, that is non-articular pain. And the next question is whether it is inflammatory or non-inflammatory condition. And the next is whether there is any pattern, a specific pattern pointing out to certain diagnosis. First, coming to articular pain. The two characteristic features of articular pain is that there will be joint line tenderness and there will be restriction of joint movement. That is, painful passive movement will be present in articular pain. Restriction of movement can also be seen in non-articular pain, such as soft tissue rheumatism and all. But articular pain, restriction of passive movement will be characteristic. And there can be swelling, crepitus, and locking of joint. Non-articular painful conditions, usually commonly called as soft tissue rheumatism. There are many structures related to the joint, bursae, tendons, ligaments. These all can give rise to pain. So these are called non-articular painful conditions. Examples: plantar fasciitis, periarthritis of shoulder, tennis elbow, Baker's cyst, and some systemic conditions. Then hepatic neuralgia, diabetic neuropathy, and even generalized pain of vitamin D deficiency can cause non-articular painful conditions. We will discuss it later. Then, as family practitioners, we will be very familiar with the term masquerades. Some conditions can mimic joint pain, and they can present as joint pain. So we have to think beyond rheumatoid arthritis, osteoarthritis, and all. These are first thing is diabetes mellitus. Diabetes mellitus can cause mild to moderate painful arthropathy. Then thyroid. Hypothyroidism can produce muscle wasting arthropathy. Hyperthyroidism can produce acropathy of the digits and clubbing, swelling, and all. This is regarded as pseudo gout. Then many drug-induced arthritis are there. So in every patient with joint pain, we should ask drug history. If he is taking any anti-epileptics, chlorpromazine, this can produce drug-induced lupus. Then thiazide and furosemide diuretics can precipitate acute attacks of gout. And also ask about the IV drug abuse. It may be a pointer of septic arthritis. Then anemia and spinal dysfunction, deformities, these all can produce joint pain. Then depression. Depression can be a part of certain syndromes like fibromyalgia and all. And depression itself can present as joint pain. Then psychological factors. Psychological factors are very much related to the joint pain. And then one thing we have to know is growing pain. Especially these are seen in 3 to 8 years of year old children. Pain will be more at night, mainly lower limbs and all. The child will be very symptomatic, but it will resolve with paracetamol and gentle massaging and all. The next morning, child will be free of pain. So in this case, all these investigations will be normal. So we have to reassure the parents. And one thing is that we have to differentiate it from juvenile idiopathic arthritis, as juvenile idiopathic arthritis can produce serious effects. So we have to differentiate it from this. Then there are many association of arthritis. In a patient coming to us with gout, we have to rule out if there is any chronic kidney disease, if he is on diuretics and all. Then an elderly patient comes to us with back pain, which does not relieved by rest or any medications, and it is progressive. We have to think about multiple myeloma and ESR as serum electrophoresis we have to do. Then myositis, that is proximal muscle weakness, bilaterally symmetrical proximal muscle weakness. The patient may be unable to stand from the sitting position and all. This can be associated with a malignancy in 40 to 60 years of age patients. Then diabetes mellitus and hypothyroidism can produce carpal tunnel syndrome. Beyond treating the carpal tunnel syndrome, we have to rule out if there is diabetes mellitus and hypothyroidism. Then referred pain, we all know about the shoulder pain in coronary insufficiency. The pain may be radiating through the shoulder. Then another entities, though very rare, rupture of aortic aneurysm can produce back pain. The pain will be sudden and intense. If it is thoracic back pain, rupture of thoracic aortic aneurysm, and lower back pain will be rupture of abdominal aortic aneurysm. We have to keep in mind. Then coming to the various patterns of arthritis, first we have to ask the patient about the mode of onset. If the patient can remember when it started, that is the easy way of acute arthritis. The patient usually remember when the arthritis started. Common examples are septic arthritis, reactive arthritis, viral arthritis. Viral arthritis, the difference from reactive arthritis is that viral arthritis is usually self-limiting and will be within 10 days of infection. Symmetrical involvement will be there, and it doesn't produce any damage to joint and all. Reactive arthritis comes after the viral infection. Then gout, trauma, these all can produce acute. Then in insidious arthritis, most systemic inflammatory arthritis and all, patient cannot remember exactly when the pain started. So these are seen in rheumatoid arthritis, spondyloarthritis, and osteoarthritis. Coming to the duration of symptoms, acute is always less than 6 weeks, chronic more than 6 weeks. In acute viral infections and all, we all know viral infections can produce muscle pain and all. These are very self-limiting. Then let us look into the number of affected joints. Monoarthritis, as the name suggests, it is involvement of single joint, one single joint. It is seen in septic arthritis, tuberculous arthritis, and in gout. Oligoarthritis is involvement of 2 to 4 joints. That is seen in gout, psoriatic arthritis, and juvenile inflammatory arthritis. Then polyarthritis, involvement of more than 5 joints. It is usually seen in rheumatoid arthritis, SLE, psoriatic arthritis. Psoriatic arthritis can present in different ways. It can present as oligoarthritis or polyarthritis. Then regarding the distribution, we have to assess whether the distribution of pain is symmetrical, asymmetrical, and which are the limbs involved and all. Usually, symmetrical involvement is seen in rheumatoid arthritis, SLE, and primary generalized osteoarthritis. Asymmetrical involvement is seen in reactive arthritis, spondyloarthropathies, rheumatic fever, and all. Both upper and lower limbs are involved in rheumatoid arthritis, SLE, and psoriasis, but predominantly lower limbs are involved in gout and spondyloarthritis. Then coming to the various patterns of joints affected, we all know rheumatoid arthritis usually affects the small joints of the hands and feet predominantly, but it can affect large joints also. Then SLE, systemic sclerosis, these all usually affect small and large joints. Then predominantly large joints are affected in spondyloarthritis, such as ankylosing spondylitis. Then some specific joints are affected in certain conditions. Rheumatoid arthritis usually spares the distal interphalangeal joint. It is very uncommon to get distal interphalangeal joint in rheumatoid arthritis. Distal interphalangeal joint is affected in osteoarthritis, psoriasis, and systemic sclerosis. Proximal interphalangeal joint affected in rheumatoid arthritis. And first carpometacarpal joint is typical affected in osteoarthritis of the hand. Spine, as the name suggests, spondyloarthritis, spine is always involved. Spondyle means vertebra, but spondyloarthritis involves spine. And rheumatoid arthritis usually involve cervical spine. Then the next question is whether the pain is inflammatory or non-inflammatory. This we can get from the history from the patient. We have to ask about the nature of the pain when it starts. If
Sorry, Nishana, your voice is getting breaking. അശ്വതി, നിഷാനന്ദ ഇഷ്യൂ ഒന്ന് എനിക്ക് പറയാൻ
സർ അത് നിഷാനെ, അത് കണക്ഷൻ ഇഷ്യൂ ആണ്.
Am I audible?
Yes, but the voice is not that clear.
Am I audible?
നിഷാന വോയിസ് ബ്രേക്ക് ആവുന്നുണ്ട്.
Voice break.
ഇപ്പൊ കേൾക്കാം.
Okay.
പേരെന്താ?
അശ്വതി ഒന്ന് ഫോൺ വിളിച്ച് എൻക്വയറി ആവോ നിഷാനയുടെ അടുത്ത്?
ഞാൻ അടുത്തുണ്ട് സിസ്റ്റർ. ശരിയായിക്കൊണ്ടിരിക്കും. ശരി.
ഓഡിയോ വേറെ ആളെ കണക്ട് ചെയ്താ പോരെ?
അടുത്ത് വേറെ ആളുണ്ടെങ്കിൽ
ഇത് മാറ്റി കണക്ട് ചെയ്തിട്ടുണ്ട് തോന്നുന്നു അല്ലേ?
അടുത്ത് വേറെ ആളുണ്ട്, അവരെ ഒന്ന് കണക്ട് ചെയ്യാൻ പറ്റൂലേ?
കണക്റ്റഡ് ആയോ അശ്വതി?
സർ സ്ലൈഡ് ഇല്ലാതെ വീഡിയോ മാത്രമായിട്ട് ചെയ്തോട്ടെ.
സ്ലൈഡ് ഇല്ലാതെ
ഓഡിയോ വീഡിയോ മാത്രമായിട്ട് സ്ലൈഡ് ഉണ്ടാവില്ല.
സ്ലൈഡ് കണക്ട് ചെയ്യാൻ പറ്റുന്നില്ല.
എന്താ കണക്ട് ചെയ്യാൻ പറ്റാത്ത? സ്ലൈഡ് ആണോ അല്ല ഓഡിയോ ആണോ?
വേറെ ഫോൺ വെച്ചിട്ട് വീഡിയോ ആയിട്ട് മാത്രം.
സ്ലൈഡ് കമ്പ്യൂട്ടറിൽ കണക്ട് ചെയ്യാൻ പറ്റില്ല.
സ്ലൈഡ് ഷെയർ ചെയ്യാൻ പറ്റുന്നില്ലെങ്കിൽ ഓഡിയോ ആയിട്ട് പോട്ടെ, വെയിറ്റ് ചെയ്യണ്ട. അപ്പൊ മീൻ ബൈൽ ആരെങ്കിലും അടുത്തുണ്ടെങ്കിൽ സഹായിച്ചു നോക്കും ഷെയർ ചെയ്യാൻ പറ്റും.
വേറെ ഒരാളെ സ്ലൈഡ് ഷെയർ ചെയ്താൽ മതി.
സ്ലൈഡ് വേറൊരു ഫോണിൽ നിന്ന് ഷെയർ ചെയ്തോളൂ, അല്ലെങ്കിൽ വേറൊരു സിസ്റ്റത്തിൽ ഷെയർ ചെയ്തോളൂ.
സ്ലൈഡ് ഗ്രൂപ്പിൽ ഇട്ട് കഴിഞ്ഞാൽ വേറെ ആരുടെയെങ്കിലും ഫോണിൽ നിന്ന് ഷെയർ ചെയ്യാം.
ഹലോ മാഡത്തിന് വീഡിയോ മെയിൽ ചെയ്തിട്ടാ കിട്ടിയോ? എങ്ങനെ ഡയറക്റ്റ് പ്രസന്റ് ചെയ്യട്ടാ?
ഇത് മാഡത്തിനൊക്കെ ഈ മെയിൽ ചെയ്യാൻ പറ്റുമോ? നമുക്ക് ഇതിന് എന്റെ അടുത്ത് ഉണ്ടോ? ഉണ്ടോ? മെയിൽ ചെയ്യാൻ പറ്റുമോ?
അല്ല ഇതിന്ന് എങ്ങനെ മെയിൽ ചെയ്യാം? ഹലോ
പ്രസന്റേഷൻ ഫോണിലുണ്ടെങ്കിൽ ഗ്രൂപ്പിൽ ഇട്ടാലും മതി, ആർക്ക് വേണം ഷെയർ ചെയ്യാം. അപ്പോൾ
വാട്സാപ്പിൽ സ്പൈസ് റൂട്ടിന്റെ ഗ്രൂപ്പിൽ ഇട്ടാ മതി.
നിഷാന, ഇനി സ്ലൈഡ് ഷെയർ ചെയ്യാൻ പോസിബിൾ അല്ലെങ്കിൽ ടോക്കുമായിട്ട് മുന്നോട്ട് പോയിക്കോട്ടെ. സ്ലൈഡ് ഇല്ലാതെ തന്നെ പ്രസന്റ് ചെയ്തോളൂ. മീൻ വൈൽ ആരെങ്കിലും ഇതൊന്ന് ഷെയർ ചെയ്താൽ മതി. Sorry, Emil sir and the senior members for making you wait. An unexpected interruption.
I don't have any issues. I can wait, no issues. If there are any questions, you can ask so that we can save the time.
Thank you, sir. So if anyone want to ask any questions regarding rheumatology or this pertinent topic,
I'll just say a few things that I think she forgot to add. One is,
sure, sir.
One of the commonest things that we find as a masquerade is none of these things that she has mentioned, but hypermobile joints. Any person, at least what we say is 1 out of 5 can have hypermobility of the joints. So when you do some routine activities itself, it can cause pain. And some of them will present with joint swelling or features similar to arthritis. More often it is non-inflammatory kind, but a young girl or a young person with joint pains, that also has to be kept in mind. And another thing is, for children, we have to always give the benefit of the doubt, because you have to be a bit more aggressive in evaluation, or you have to be a bit more cautious when you approach a child with joint pains, because of two reasons. One, they may not always give a correct history. So we have to be more in an examination mode to make sure that there is definite tenderness of the joint, definite swelling of the joint or pain when we press the joint. And second thing is, you have to always keep in mind arthritis, which if it develops at a young age, it can cause deformities. So that has to be prevented. Growth abnormalities can occur, that has to be prevented. And another thing is malignancy also can happen in children with joint pains. So that also has to be kept in mind when we see a kid with joint pains. Other than that, I think till now she has covered really nice.
Thank you, sir. I think she has joined. Nishana?
Yeah.
If Sarah has completed.
Sir, I'm joined from another device.
That's fine. You can just share this.
But I cannot share the slides and all. Slide കിട്ടുന്നുണ്ടോ? ഇല്ല, without slides.
Nishana, you can continue without slides. Meanwhile, someone can share from there.
Okay.
Is the share screen slides is there with you? Someone is there with you?
But I have problem with connections with laptop.
Okay.
Now, I try once again sharing.
Sharanbhai is there?
Yeah, I'm here.
Can you just share for her?
Yeah, please share. Please share me the slides either in WhatsApp or.
Hello.
ജുബേരെ co-host ആവണം തോന്നുന്നു ഷെയർ
ഹലോ ഡോക്ടർ രശ്മി ഹിയർ. ഞാൻ ഷെയർ ചെയ്താൽ മതിയോ?
മതി മാഡം.
ഞാൻ ഷെയർ ചെയ്യാം. എന്നെ ഒന്ന് എനേബിൾ ചെയ്തേക്കാം, ഞാൻ ഷെയർ ചെയ്യാം.
മാഡം സ്ലൈഡ് ഫോർവേഡ് ചെയ്യാൻ പറ്റും?
ഇൻഫ്ലമേറ്ററി.
ഒരു സെക്കൻഡ് ഞാൻ ഓക്കെ. ഈ സ്ലൈഡ് ആയിരുന്നില്ലേ? ഇവിടെ ആയിരുന്നില്ലേ?
ഇല്ല മാഡം, അത് നീങ്ങിട്ടില്ല.
ഹലോ
മാഡം ഒന്ന് ബിഗ് സ്ക്രീൻ ആക്കിയിട്ടെ, ഫുൾ സ്ക്രീൻ ആക്കിയിട്ട്
മാഡം എനേബിൾ എഡിറ്റിംഗ് ചെയ്യണം മാഡം.
എന്തോ
എനേബിൾ എഡിറ്റിംഗ് ചെയ്തിട്ട് സ്ലൈഡ് ഷോ മോഡിലാക്കണം മാഡം.
ഒരു സെക്കൻഡ്.
ഫസ്റ്റ് തന്നെ നിൽക്കുക.
ആണോ? ഒരു സെക്കൻഡ്.
ആ പേജിന്റെ മേളില് യെല്ലോ ഹെഡറിന്റെ മുകളിലുണ്ട്.
മനസ്സിലായി. മനസ്സിലായി. ശരിയായോ? ഹലോ
ശരിയാ മാഡം.
ഓക്കെ. നിശാന പ്രസന്റ് ചെയ്തോളൂ.
And then we
നിശാന പ്രസന്റ് ചെയ്തോളൂ, ഞാൻ സ്ലൈഡ് ചേഞ്ച് ചെയ്തോളാം.
നിശാന മ്യൂട്ട് ആണോ?
Okay. Am I audible?
Yeah. Audible. Yeah.
As we already said, we have to distinguish between inflammatory and non-inflammatory conditions. Inflammatory is commonly seen in rheumatoid arthritis, SLE, reactive arthritis, and all. The characteristic features is it aggravate on rest. That is, it can worsen at night, and morning stiffness will be more than 30 minutes. It always improves with activity. There can be flares. There are systemic features like fever, fatigue, weight loss, and acute phase reactants can be elevated. A full blood count show anemia of chronic disease, leukocytosis, thrombocytosis, or raised ALP. Then sequence of involvement. There is intermittent attacks in gout, Behçet's, and Reiter's disease. Addictive involvement of joints is seen in rheumatoid arthritis, spondyloarthritis, osteoarthritis, and psoriasis. Migratory involvement is seen in rheumatic fever, gonococcal, viral, and bacterial endocarditis. Then extra-articular features, which are always giving clue to the diagnosis. Fever can be seen in SLE, JIA, vasculitis, rheumatic fever, and adult onset Still's disease. Mucosal lesions can be seen in SLE, psoriasis, Behçet's can present as oral ulceration, reactive arthritis, gonococcal arthritis, and vasculitis. Typical eye findings such as scleritis, episcleritis in rheumatoid arthritis, and conjunctivitis in Reiter's syndrome. Then nodules, extensor tendon nodules are very common in rheumatoid arthritis. Osteoarthritis can present as Heberden's nodules, Bouchard's nodules, and gout can present as arthritis. Then some dermatological manifestations will be giving clue to the diagnosis. SLE can present as alopecia, and scales can be seen in psoriasis. Salt and pepper spots, puckered mouth, pinched nose, tight skin. These all suggest systemic sclerosis. Nail pitting, sausage-like fingers. These are all seen in psoriatic arthritis. Vasculitis secondary to RA and SLE may show digital gangrene. Interstitial pneumonia can be seen in rheumatoid arthritis, SLE, and systemic sclerosis. Then, as we already discussed, soft tissue rheumatism is affection of the structures near to the joint. They can be mechanical, inflammatory, crystal deposition, and they can be regional pain syndromes. The most important one is fibromyalgia, that is diffuse pain syndrome. It is the most common generalized pain syndrome we can see in general practice. This diagnosis is essentially clinical. It is very disabling, disabling more than the arthritis per se. Here, the routine household activities and office work all will be very difficult. It is a disorder of abnormal pain perception. The patient will be having allodynia or hyperalgesia as pain perception is exaggerated. So all the investigations will be normal. Usually females are 7 to 9 times more affected than men, and there will be history of widespread pain for at least 3 months. And widespread pain defined as being present bilaterally above the waist, below the waist, axial skeleton, and all. That is the first point. Then on examination, there will be pain on digital palpation. The pressure of digital palpation is just sufficient to cause the nail bed blanching. So pain on digital palpation on at least 11 of the 18 described points. These points are around lower neck in front, edge of the upper breast, below the side bone at elbow, and just above the knee on inside, anteriorly. Posteriorly, base of the skull, neck and shoulder, upper inner shoulder, upper outer buttock, and hip bone. These areas can be palpated and look for tenderness. If tenderness is present at least 11 areas and the patient complains of persistent bilateral diffuse pain for more than 3 months, we can diagnose fibromyalgia. But we have to do a full blood count, CRP, ESR, or RFT, LFT in suspicious cases. At TSH, hemoglobin, these all will help to rule out other causes. Then the most common thing, another most common thing we have to deal with is low back pain. The main thing in dealing with low back pain is we have to distinguish between an self-limiting mechanical back pain with the inflammatory back pain, or we have, most importantly, we have to look for radicular pain and any red flags for possible spinal pathology like cauda equina syndrome. Acute mechanical back pain usually affects persons with the 20 to 55 years of age group. There will be a history of antecedent unaccustomed activity or lifting weight or bending. Usually the acute mechanical back pain confined to lumbosacral region, buttock or thigh. It usually does not radiate beyond the knee. It is a key point. It does not radiate beyond the knee, and there will be no neurological signs, no paresthesia and all. The pain is always asymmetrical. The patient's main complaint will be back pain. Then there will be no systemic features. Then non-mechanical back pain. Non-mechanical back pain or inflammatory back pain, there will be morning stiffness in ankylosing spondylitis and all. Then we have to rule out radicular signs. Radicular signs is affection of the nerve root. Here the patient's main complaint will be leg pain. Unilateral leg pain will be more than the back pain itself. Unilateral leg pain will be more than back pain. So, and there will be distribution, paresthesia or numbness along the distribution of the back pain. Patient, we have to specifically ask for any difficulty with micturition, saddle anesthesia, that is anesthesia around the perianal region, or any gait disturbances. This all will rule out cauda equina syndrome. If the patient complains of perianal anesthesia, we have to refer the patient immediately for neurosurgery assessment and further treatment. And regarding the radicular pain, the patient is complaining of more unilateral leg pain, paresthesia, on examination reflexes are lost, and multiple neurological signs levels, then we have to ask the duration of symptoms. If it is more than 4 weeks, and then we have to do further investigations like MRI and all. Coming to an overview of musculoskeletal investigations, just the basic things. First is synovial fluid analysis. Synovial fluid analysis is very important in acute monoarthritis. Inflammation is there. Synovial fluid volume increases, cell count increases, viscosity reduces. These are the features in inflammation. There will be uniform blood staining in bleeding diathesis, pigmented villonodular synovitis, and trauma. Supernatant lipid layer can be seen in intra-articular fractures. Sepsis, if we are suspecting sepsis, we have to analyze synovial fluid analysis with a gram stain, culture, antigen test, and all. Then a plain X-ray in our general practice can give lot of information because in osteoarthritis, we can see the joint space narrowing, osteophytes, osteosclerosis, and in rheumatoid arthritis and all, we can look for joint erosion, ankylosing spondylitis. In later stages, bamboo spines, syndesmophytes, marginal or central erosions, and in some systemic inflammatory diseases like SLE and all, there will be no deformity and erosion, so we can rule out. Then soft tissue swelling and rough idea about the bone density can also be obtained through the plain X-ray. CT has limited tissue resolution, so MRI is preferred. It can detect and assess pathology of intervertebral disc, soft tissue, and periarticular structures. UC can guide in aspiration, injection of steroids, and all. Then a word about blood investigations. CRP and ESR will be elevated in all inflammatory conditions. A full blood count before the diagnosis and after the during the treatment, it has a definite role because in inflammatory conditions, full blood count will be elevated. It can cause leukocytosis, thrombocytosis, and there will be anemia of chronic disease. And serum ALP will also be elevated. After treatment with many of the DMARDs, we have to monitor the full blood count first during the 2 weeks. First after 2 weeks during the initiation of treatment, then monthly and 3 monthly, we have to monitor this full blood count for any bone marrow suppression. Then serum calcium level we can assess. Serum vitamin D. Vitamin D deficiency is very common now, and it can cause generalized back pain. Then autoantibodies, rheumatoid factor, it is very commonly done. It is positive in 70% of rheumatoid arthritis. But the problem with rheumatoid factor is that rheumatoid factor is not that much specific. Anti-CCP antibodies are having same sensitivity but more specificity. In SLE, we do ANA. It has got low specificity. Anti-double stranded DNA antibodies are used. Then antibodies to extractable nuclear antigens in many conditions. Anti-histone antibodies in drug-induced lupus. Then anti-Rho, anti-RNP, anti-centromere, anti-SCL70, anti-topoisomerase. These are done in various conditions. Then a word about principles of management in musculoskeletal disorders. First thing is we have to educate the patient. We have to give a proper idea about the prognosis of the disease, how the patient can, so the patient should have to accept the prognosis of the disease and lifelong medications and all. We have to counsel the patient. Then we have to control the pain if there any. Then optimize the function of the joint and modify the disease process wherever possible, like in rheumatoid arthritis, JIA and all. Then the treatment will be always patient-centered according to the patient's needs, occupation, age group, financial things and all. Then exercise is very important in arthritis. There is no need of complete rest. There is activity is spaced with rest. That is brief, long or heavy activity is divided into segments, and patient can do it with breaks. That is spacing of activities. Same condition is applicable for exercise also. First, aerobic conditioning exercise will reduce the pain, disability and all. Then local strengthening exercise. Local strengthening exercise of the muscles near the joint is very important to prevent the pain and disability. Then a word about BMI. BMI we know that BMI, if it is very high, it can overload the joint. That is osteoarthritis can be more. We usually ask the patient to reduce the BMI. Reducing the BMI beyond a level will also harm the patient by making him more prone to fractures. Then avoid the squatting, folding legs. These all are needed. Usually in our patients, we have to ask specifically to avoid Indian toilets. Then pharmacological options, mainly regarding the analgesia. Analgesia, first we have to give paracetamol 1 gram 4 times a day. Then regarding the NSAIDs, we have to use NSAIDs judiciously according to the age group, one thing. Then any previous history of upper GI bleed, we have to avoid long-term NSAIDs, prescribe PPIs along with NSAIDs, and avoid prescribing glucocorticoids along with NSAIDs. In chronic conditions, the celecoxib, etoricoxib, these COX-2 inhibitors have reduced potential to cause upper GI bleed. So these are preferred. Nutraceuticals like diacerin, hyaluronic acid, these all are seen. Then corticosteroids, anti-inflammatory action is there and immunosuppressive action is there. These both are benefited in various arthritis. Then oral, parenteral and local steroids are available. In soft tissue rheumatism like plantar fasciitis and all, we do local corticosteroid injection, and they help to maintain remission and they control the disease activity. Then disease modifying antirheumatic agents, very common and well tolerated hydroxychloroquine. Hydroxychloroquine is safe in pregnancy. And there is no need of monitoring full blood count and LFT here, but we have to need a basic visual function assessment as long treatment can cause retinopathy. Other drugs are methotrexate. While prescribing methotrexate to a female in a reproductive age group, we always have to ensure effective contraception and always supplement methotrexate with the folic acid. Then azathioprine, leflunomide, cyclophosphamide, mycophenolate mofetil. These all are used according to disease conditions. Gold and all are rarely used now. Then biologic agents, anti-TNF, infliximab, adalimumab, these are very common. Then a brief overview about the diseases. Osteoarthritis, as we all know, usually it affects small age group more than 50 years. Usually females are mostly affected. Obesity, previously deformed, previous trauma of the joint, these all are risk factors. Pain is, it is a non-inflammatory condition, so pain increases with activity and relieved by rest. X-ray can show finding, we have already discussed, osteophytes can be there, reduction of joint space. These all can be seen. Crepitus can be felt by the patient itself. If the patient is having very much disability, we have to refer the patient for surgical intervention. Then rheumatoid arthritis. It is also seen in females, typical age group 30 to 50 years. Symmetrical involvement of the proximal interphalangeal joints, metacarpophalangeal joints of hands, wrist, base of toes, mainly hands and foots. It is worse at rest, better with activity. There can be extraarticular features. RA factor, anti-CCP, these all will be positive. We have to treat with NSAIDs. DMARDs are initiated. Then supportive treatment is necessary. Long-term treatment is necessary. Then seronegative spondyloarthritis. As the name suggests, these all affects the vertebrae. Ankylosing spondylitis, reactive arthritis, enteropathic arthritis, psoriatic arthritis, these all come under this group. Ankylosing spondylitis is seen in males, contrary to other conditions we have discussed. This is more common in males and typical age group less than 40 years. Mainly sacroiliitis and peripheral oligoarthritis, asymmetrical arthritis, especially the large joints are affected. Iridocyclitis, and in later stages, chest dysfunction can occur. We all know HLA-B27. HLA-B27 can be positive, but it is very expensive test and it can sometimes be false positive. So no need to do HLA-B27 in all case of ankylosing spondylitis. Then psoriatic arthritis, we have to ask the history of psoriasis in family, psoriasis in patient itself, any medicines, then skin manifestations, sausage digits, pitted nails. These all will be clue. It can occur at any age, and males and females are equally affected. NSAIDs, supportives, and DMARDs are given. Then enteropathic arthritis is arthritis seen in patients with the inflammatory bowel disease, ulcerative colitis, Crohn's disease, etc. Here also, as every spondyloarthritis, lower extremities are most commonly affected. Colonoscopy can diagnose ulcerative colitis, Crohn's disease, and all. Then reactive arthritis, this is very different from viral arthritis. Acute viral arthritis usually subsides within 10 days of the infection, but reactive arthritis occurs after an infection. Sometimes the first infection may not be that much severe, so the patient would not remember. Then genitourinary infections can cause reactive arthritis and post-dysentery reactive arthritis. Usually it is seen in younger age group. Lower extremities are mostly affected. Preceding dysentery, cercinate balanitis, and keratoderma blennerhagica, crusted lesions over the palms and soles. These will be seen in reactive arthritis. ESR and CRP will be elevated. Specific serology can be diagnostic. Then crystal-associated diseases. Crystal-associated diseases are acute gout, acute pseudo-gout. Then coming to gout, gout is also very common in general practice. Typical age group is males 40 to 50 years. Estrogen is said to be uricosuric, so it is very, very uncommon in females less than females in a reproductive age group. Big toe MTP joint is usually affected. There can be other lower limb joints are also affected. Tophi, raised serum uric acid, urate crystals in synovial fluid. These all are diagnostic. But we have to note that in acute phases of gout, that is in acute flares, the serum uric acid may be perfectly normal. So this due to acute inflammatory process, uric acid will be low. So synovial fluid analysis, ESR, CRP, this should guide the diagnosis. Then we have to keep in mind that during acute attack, never give uricosurics or urate lowering drugs. Acute attack is treated with the NSAIDs, colchicine. If possible, 1 or 2 joints are affected, then joint aspiration, and in resistant cases, intra-articular steroids. Urate lowering drugs have specific indication. For single episode, we do not usually start urate lowering drugs. Episodes more than one or two, more than 2 episodes in 1 year, we can start. And if there is evidence of renal damage, nephrolithiasis, then we can start urate lowering drugs. Then uricosurics are only given in low urate excretors. Coming to pseudogout, pseudogout is a disease of an elderly, mostly knee. Chondrocalcinosis and pyrophosphate crystals in joint can be seen as synovial fluid analysis. Here, NSAIDs, colchicine, these all can be given. Colchicine usually avoided in elderly. Then we have already discussed viral arthropathies. Here, transient polyarthritis can be seen. Human parvovirus, hepatitis B, C, rubella, and even chikungunya can cause viral arthropathies. HIV can produce a wide variety of articular symptoms. Then one emergency condition, septic arthritis. It is a rapid destructive medical emergency, usually hematogenous spread. Risk factors are increasing age group, pre-existing joint disease, any immunosuppression, diabetes mellitus, IV drug abuse. We have to be very cautious. Then acute and subacute monoarthritis, fever, swollen red hot joint. These all are seen. Mainly lower limb joints are affected in septic arthritis, especially hip and knee joints. Once we deal with septic arthritis, we have to do synovial fluid gram stain culture. Then management, first pain relief, oral or IV analgesics can be given. Then IV antibiotics has to be started, flucloxacillin, clindamycin. If we are suspecting gram-negative gentamicin, then modified according to the culture reports. Then systemic connective tissue diseases can produce arthralgia. SLE can, 90% of the patients can produce arthralgia in SLE. There is symmetrical and variable arthritis. Small joints are often affected. Diagnosis is by ANA by immunofluorescence we can do, and antibodies to extractable nuclear antigens, as we already discussed, and low complement level. analgesics, NSAIDs, corticosteroids, HCQ. These all can be used in treatment. Then scleroderma, skin manifestations are typical. Patient can have dysphagia, Raynaud phenomenon, other skin changes. Here diagnostic are SCL70 anti-centromere antibody. Joint involvement is usually mild. It can be treated with analgesics. Then another thing we often miss is polymyalgia rheumatica. It is a disease of elderly. Females are most commonly affected. It is associated with the systemic vasculitis of large vessels, symmetrical. Here we can see the morning stiffness of the upper extremity, especially shoulders. There can be constitutional symptoms. ESR is elevated, fever, malaise, and night sweats can be seen. Here, steroids are usually given. Our role as a family practitioner, first thing is early identification of the disease pattern through accurate history and clinical examination. We can know whether it is inflammatory, whether it is acute, chronic, any systemic disease we are suspecting. We can identify the emergencies like septic arthritis. We can identify fibromyalgia and manage accordingly. Then recognizing the red flag signs, any systemic features, fever, lymph nodes, rash, that type of and weakness, muscle weakness, myositis, these all can be red flag signs. And Coda equina syndrome, as we already discussed, in case of back pain. Then judicious use of investigations. We have to use specific investigations according to the clinical suspicion. And then appropriate referral, it is very important. And then when to refer. Most severe inflammatory disorders. If we are suspecting an true inflammatory disorder like rheumatoid arthritis, we have to refer the patient for the diagnosis and treatment initiation. Then same as applicable for spondyloarthritis. We have to confirm the diagnosis, and rheumatology referral is important. Then osteoarthritis, in severe cases with progressive osteoarthritis and even surgery is contemplated, that cases we can refer. Then undiagnosed arthritis in presence of constitutional symptoms like fever, weight loss, sweats, that we can refer. Then intractable or worsening symptoms, persistent joint inflammation, children with suspected JIA, and septic arthritis we already discussed. It is a medical emergency, so we have to refer. And this in short about arthritis.
Now, good evening, everyone. I think the talk was relatively
Thank you.
nice. I think she has covered almost most of the things that we commonly encounter. I have received actually 3 questions. Can I go to the question and answer session? Is there any further question? Yeah. First question was how to manage a seronegative spondyloarthritis in general practice. The thing is, as such, seronegative arthritis, it's going to be a big challenge. You have to first confirm that it is seronegative. For that, we have to take a detailed history to rule out various systemic involvement and various disease syndromes. Then we basically go for the basic antibody evaluation. That's a must to make sure that it is seronegative. That's basically ANA, anti-CCP, and rheumatoid factor. And try to go by a criteria-based diagnosis. For general practice to be always safe, we have to follow the criteria. So there is a AS criteria for spondyloarthritis. And if you can fit it into that criteria, you can be relatively certain that up to sensitivity is almost up to 90% specificity. So you can be relatively certain that you are dealing with seronegative spondyloarthritis. But to make sure that they fit into the criteria, one of the 2 things should be positive. One is HLA-B27, it should be done by PCR. And second is MRI. Either of them should be positive for you to consider that criteria. If you can fit into criteria, there is no harm in starting the medicines because time is of the essence. Any delay can cause them to develop syndesmophytes and fusion or ankylosis of the joint. So we have to start immediately. But we all start is basically NSAIDs. And for that matter, any NSAID, if the person has got no renal complaints, is okay. As long as he tolerates that, you can start on the NSAID. And once he starts responding to NSAID, you can be relatively more sure that it is spondyloarthritis. And then if you are competent enough, you can start on DMARDs also, but not all DMARDs will be effective. Only sulfasalazine is said to be effective. And if they don't respond to the treatment for about, say, about 2 weeks or 2 months or so, it's better to refer, because there are so many other things, even with HLA-B2 positivity, such as malignancies, sarcoidosis, all these things also can be similar to seronegative arthritis, seronegative spondyloarthritis. Infections like such as tuberculosis, many times we find that it turns out with tuberculosis. So if the response is not adequate, we call it adequate if there is more than 50% improvement in all the parameters by around 4 to 6 weeks. So if that does not happen, always try to refer the patient for detailed evaluation. But if you are able to fit them into the ASA's criteria, and you start the medicines with NSAIDs and they show a good improvement, then you may be able to continue the medicines as long as he is responding. Now, second question I got was about colchicine in acute gout. In acute gout, if the person is quite young, any of the options, including colchicine, painkillers, NSAIDs, and steroids, is good enough. If they are contraindicated, for example, a person with diabetes or a person with renal disease, steroids and painkillers will be contraindicated. In that situation, colchicine can become the drug of choice for acute gout. When you start it sufficiently early, for example, I am just developing the acute episode and I start the tablet now, it is almost as effective or even more effective than NSAID. Only thing is, you have to start it sufficiently early. It's almost at par with NSAID and steroid. And if you feel that the disease is very severe, you can add it along with the other two medicines. It's relatively safe if they are tolerating. Most often, when they are not tolerating, they will develop loose motion, and we have to stop it. The dose we get is only 0.5 milligram per kilogram. There is a confusion because most of the text says 0.6. It's available in US, but here it is 0.5 milligram. On the first day, when the episode is very acute, you can give 0.5 milligram 8 hourly. But after the first day, you are expected to give it 0.5 milligram twice a day for up to 2 weeks. Most often, it subsides by 2 weeks, and you have to start the urate lowering therapy if it is indicated, and you can stop colchicine. That's regarding colchicine. And the third question was whether how to diagnose and manage fibromyalgia in the general practice. I would always say that even in my practice also, I keep fibromyalgia is a very open diagnosis. At any time, it can turn out to be something else. You have to be very cautious when you label the term as fibromyalgia. Many patients with psoriatic arthritis have got multiple enthesopathies. They will be having diagnosed as fibromyalgia. Malignancies can be diagnosed as fibromyalgia. So we have to do the basic investigations as she has mentioned. Make sure that you tick all the investigations as normal. Make sure that she does not have any systemic findings such as fever, weight loss, etc. Make sure that she does not have this problem with any deformities or anything like that. And this has been there sufficiently long. And always inquire for any findings for depression or any reasons for the precipitating of the event of the disease. And if you are finding no other cause and you are finding a diffuse pain which fits into the fibromyalgia criteria, you can start treatment with either most often we start with this anti-epileptic such as pregabalin or gabapentin, or antidepressants such as duloxetine or amitriptyline. And most often, either of these, when you start, they may respond. If you find that they respond, you can continue that. A reasonable dose, not more than that. And here also, if you find that they don't respond within around 4 to 6 weeks, or if they develop new findings, always refer the patient, because as I told, many of the connective diseases, sarcoidosis, malignancies, infections, etc., can also mimic fibromyalgia. Those are the 3 questions I got. Any other questions? Let me see. Another question is there any superiority for febuxostat versus allopurinol? Yes, febuxostat is supposedly more effective, faster acting, and more probably adverse event prone compared to allopurinol. Allopurinol, the advantage is that it has got a cardio protective effect. It reduces hypertension. And it actually has got a long-term beneficial role compared to febuxostat. But the cardiotoxic role of febuxostat is not even proven even now. And it has got an added advantage that it can be preferred in renal failure and in elderly who can develop allopurinol hypersensitivity in up to 2%. So if the person is relatively old, person is having some renal problem, better prefer febuxostat. Whereas if the person is relatively young and he may need a medicine for a longer period of time, uric acid is not that high, always try to prefer allopurinol. And when you start allopurinol, make sure of 2 things. One is they have to be started at a very low dose, probably 100 or alternate day or 100 milligram per day. And gradually you can titrate it up to 600 or 800 milligram per day. And an important thing is that when you start febuxostat and or allopurinol for that matter, make sure that they are not taking azathioprine, because I have seen at least 2 patients developing dangerous complications due to azathioprine hyperactivity or toxicity because of the dangerous interaction with these medicines. So always keep that in mind. And another thing is duration of treatment with febuxostat. There is no duration as such. What we usually do is for short term, you don't say any duration. It all depends on how fast the person improves. The target we keep is, it's a treat to target disease. The target we keep is usually 5. So once the uric acid comes below 5, you can gradually taper the hypouricemic therapy, either febuxostat or allopurinol. If it is not reaching 5, you can actually think of increasing the dose and maintain a target around 5, and it has to be maintained. So you may have to take the medicine long term. So that is why we say if the person has got multiple episodes, if the person has got renal problem, if the person has got very high colchicine levels, renal stones, etc., then only you start long-term hypouricemic therapy, because you cannot suddenly stop it just saying that uric acid level is. Many times they stop it and they develop another flare and come back, and they will be losing the trust in starting the medicine also. Another question is role of nutraceuticals like dioxazine and glucosamine. It's actually effective only in a certain selective small group of people who develop their osteoarthritis at a very young age or in early osteoarthritis. It basically supports the improves the functional status, but it does not have any effect on the osteoarthritis status unless and until the person reduces the effort put on the knee, unless and until the person reduces the joint strain, do regular physiotherapy, osteoarthritis will not improve. But this will actually improve the functional status so that they can do exercises much better. In advanced stages, most often the problem is osteoarthritis. When they are afraid of surgery, they take these medicines, which is not going to help them. Only in early stages only it will help. But there are certain subset of patients who relatively feels, either it may be placebo effect or it may be true effect, who feels the improvement with these medicines. They are not disease modifying drugs. They are just symptom relievers. Now, another question is criteria for referring the patient for biologicals. There is no criteria as such. As of now, as of the newer guidelines, you can start biologicals from the time of diagnosis itself, depending on the severity and the need of the person. What we usually say is, if Virat Kohli or Sachin Tendulkar develops rheumatoid arthritis and they need to be treated fast, they have to be treated with biologicals, because that is the only thing that will prevent the deformity developing fast. All the other things will take time. But if I develop rheumatoid arthritis, I may not go for biologicals initially, because I will always try for DMARDs, before doing that, unless and until I am having a rapidly progressive or very severe disease. So as of now, if you find that the person has got, as she rightly mentioned, if the person has got inflammatory arthritis, always refer, because these patients, it could be because of malignancy, it could be because of a deforming arthritis. Any delay can cause deformities. It could be some manifestation of SLE. At a later stage, SLE can actually develop into life-threatening complications. So you have to diagnose that at the earliest, and you have to treat. And if it turns out a rheumatoid, if the person desires, they may have to be started on biologicals at the onset itself. Initially, we used to keep it as a reserve drug, but now, because more and more evidence are showing that at the earliest, if you start treating, they are unlikely to develop deformities. Now, biologically is actually a choice. If they want, they can start it early. Another question is, any association hypothyroidism with high uric acid? Yes, hypothyroidism and hyperthyroidism both can cause high uric acid due to different mechanisms. And is that necessary to put on uric acid lowering agents? No. Most often, the uric acid related to hypothyroidism or hyperthyroidism due to metabolic causes. Once you correct the hypothyroidism, the uric acid tends to normalize, and you don't need medicine in those conditions. Now, are DMARDs absolutely contracting osteoarthritis? No. In a subset of osteoarthritis, inflammatory osteoarthritis, erosive osteoarthritis, methotrexate, hydroxychloroquine, sulfasalazine, all have been tried with the effect. In some studies, anti-TNF itself has been tried with a good effect. So it all depends on the pathogenesis. If there is inflammation, you need DMARDs. If there is no inflammation, you don't need DMARDs. It's as simple as that. So that finishes the questions. Now, one more question. Effectiveness of PRP in osteoarthritis. PRP, there is a small subset of patients who, as I told, similar to nutraceuticals, who develop cartilage disease very early. And if the cartilage disease is not advanced, PRP actually may revert those things. But in established osteoarthritis, most often the sad thing is that most often the patients who come to us with X-rays showing osteoarthritis, it's not going to help. If the person has got osteoarthritis very early, that basically the joint crepitus is there, but X-ray is relatively normal or stage class 1 or 2. If the person has got very symptoms but not much findings in the clinically or X-rays, in those patients it may help. Other than that, it's not going to help. Any other questions? I think one more has come. No further questions.
If anyone want to ask question, you can just unmute and ask.
Before.
Yeah.
Sir, before vote of thanks. Very sorry for the connectivity issues.
Is there a role for biologicals in seronegative RA?
Definitely. No, the rheumatoid arthritis, the problem is that how are you going to say it as seronegative RA? Basically, the only way to say it as seronegative RA is by two things. One is that X-rays showing typical erosions, joint space narrowing, and all those features that are related to. There are 4 things that you can find in RA in X-ray. One is joint space narrowing. Second thing is erosions. Third thing is the typical deformities or those things. And if you take MRI, you can see synovitis and bone marrow, bone edema. So if you find these things, it could be seronegative rheumatoid arthritis if the antibodies are negative. But the only definite diagnostic feature is basically biopsy. Anyway, as you told, if it's seronegative RA, the treatment is the same. You start off with DMARDs or you can start off with biologicals. Only difference is that for seropositive rheumatoid, the best option, at least from our point of view, would be rituximab, because rituximab is very good for reducing the antibody levels. But for seronegative RA, it has been found that rituximab is not that effective. So you have to go for either anti-TNF or tocilizumab. Nowadays, tofacitinib, that are more tablets, and baricitinib has come up, that also is effective. So there are options for seronegative rheumatoid arthritis. But the problem is that before you call it a seronegative rheumatoid arthritis, you have to actually rule out malignancies. It could be paraneoplastic. It could be, as she told, SLE or something else that is causing the arthritis. So those things has to be ruled out before you decide on the treatment, because tofacitinib or anti-TNF can actually worsen the lupus. That biologicals actually has got a role. Definitely.
Can the patient once we are treating any seropositive RA and we are not giving the option of biologicals, can the patient sue us that we have not given that option? Is there
No. Ideally, the person cannot sue you for things like that. They are always having a choice for seeing someone else. Only thing is, if they ask you for biological, if you say that is not needed, and if they develop deformity, then that can happen. So that's what. It's basically your choice. If you are competent to start biological, you can give. The problem is, when you give biological, you are making a diagnosis of rheumatoid. Unless and until you make the diagnosis, you cannot give. And if the diagnosis turns out to be some infection, infective endocarditis can cause subacute polyarthritis. It may be there for 5 or 6 months, and rheumatoid factor may come as positive low titers. And you start on biologicals, and the infection worsens, then that is a reason for suing you. So if you are able to competently roll out all the other causes, he has got only arthritis, there is no need to start biological immediately, because as of now, as per the criteria, there is no mandatory role for biological initially. It's only a suggestion. If the person desires that, you can start that. If you are not competent, you don't have to give that option. I don't give the option of biological for all rheumatoid arthritis. No rheumatoid arthritis, I give the biological option first. I start with DMARDs. Once the DMARDs is not effective, I go for biologicals. But the thing is, it all depends on the severity. If it's a young lady or young guy, and he has got severe arthritis, his rheumatoid factor is very high, my choice of biologicals will come early. I will not wait for 3 months or 6 months. I'll start off with DMARDs. If the response does not happen, I go for the biologicals at the earliest. Mainly because we start DMARDs because most of the people who come to us will not be able to afford biologicals for a long period of time. They cannot. It's not a 1 or 2 injection. It's supposed to be continued on a regular basis. If you are taking rituximab, you are expected to take it every 6 months. So most of us cannot afford that. So in that situation, there is nobody is going to blame you for not giving them that option. But you try to continue on steroids. You try to delay the whole treatment option. Then, if the person develops deformities, then they can see you. Most often the problem happens is they will go to some doctor and they will say, "Oh, why did you take biological? It would have cured you." It will not cure you. That's why many people, just to make them take biological, say that it will cure. It will not cure you. It's only
that
going
was my
to.
question, sir.
Yeah, it will not cure you. That's what there is no treatment as a cure for this disease. So they cannot sue you saying that you did not give me that curative option. It's a same option as DMARDs. If you are going for treating for gastric ulcer or acid peptic disease, you are giving Rantac. How can they sue you? It's saying that you are not given esomeprazole. No, it's not like that. You are starting with the best medicine you are choosing. You have got so many reasons for doing that. It's relatively safe. You know that it is relatively safe. The other medicine has so and so problems. So I am not starting you on that. That it's as simple as that. You just need to have an explanation for that. Even if you don't have any explanation, you can just say that I am not familiar with the biological, so I cannot give that without being familiar. Nobody can blame it. That's not going to be accepted in court. Only thing is they are asking for that. You are still saying no need, no need, no need, and they develop deformities. Then they can say that their deformities was there because of not being given that option. But they have always got a choice of going to some other doctor. So I don't think that's a valid reason for getting sued. If there is a curative option, if you don't give that option, they can sue you. As of now, there is no curative option for any of the diseases. Almost everything is a choice. By getting a Mercedes Benz or getting a Maruti, there is no difference. It's similar to that.
One more question is there in the chat box.
Yeah, let me see. Shall we treat latent tuberculosis before giving biologicals? Yes. The thing is, as of now, I believe that is the only indication for diagnosing latent tuberculosis. The problem is, if you are planning to give anti-TNF, I again say anti-TNF, there is a chance that if you are having tuberculosis, it can flare up. It can flare up and you will not be able to diagnose it early, and you will have a major disease by the time you diagnose it. So what we usually do is, we usually do 3 tests. One is Mando, another is TB quantiferon. I think that is only indication for quantiferon TB now. And third is chest X-ray. If any of them is suggestive of tuberculosis, you can term them as latent tuberculosis, because we don't know whether there is tuberculosis or not. Unless and until they have had a contact, it is unlikely to be positive. So you have to be on the lookout for tuberculosis. And it has been found that if you treat tuberculosis as tuberculosis in these patients and then give biologicals, they are unlikely to develop tuberculosis in the future. Whereas you find these tests negative and you start anti-TNF, more of them develop tuberculosis at 2 or 3 years. Not because of the disease being there at that time, but because we may be missing the latent tuberculosis because these tests were false negative. So initially what we used to say was, you have to wait for 1 month before you can give anti-TNF. But nowadays, you don't have to wait for 1 month. You can start anti-TNF simultaneous with ATT. And latent tuberculosis treatment is slightly different. You need only either rifampicin or rifampicin plus INH or INH alone for 1 month or something like that. There are 1 or 2 protocols for that. That's only required, no need for the complete treatment. And same thing with anti-TNF has been described with tocilizumab and tofacitinib. So in these medicines, if you're planning to give, it's better to do this evaluation for tuberculosis. And if found to be positive, give a course of ATT. I still give at least 1 month course of ATT before going for starting the biologicals. And same with vaccines also. If you are planning to give a live vaccine, it's better to give the live vaccine and wait for 2 weeks before giving the biological, because there's a small chance that the vaccine can cause a severe infection or fever, something like that, severe reaction because of taking the ATT or this anti-TNF early. For rituximab and for secukinumab, SCAFO, it's not recommended till now. There is no mandatory need for tuberculosis testing or treating, because those 2 injections are not found to increase the risk of tuberculosis.
If no more questions, we'll wind up with your permission. It was a great discussion. It was nice to have you here. I request Dr. Ashwathi, Spiceroot representative for Lutz Hospital, to express vote of thanks.
Good evening, everyone. Here we come to the end of academic session, Approach to Arthritis. So it's my privilege to have been asked to propose vote of thanks. I'm Dr. Ashwathi, second year DNB resident, Spiceroot institutional representative from Lutz Hospital. First of all, I'd like to thank Spiceroot Kerala representative, special mention to Dr. Nadeem, Dr. Mamta, and Dr. Ali Samil for giving our institution an opportunity to conduct the session. I extend my heartfelt gratitude to Dr. Emil J. Tachil for accepting our invitation to chair the session, for his precious time and for the discussion. My most special and heartfelt thanks to Dr. Nishana, my senior, for her effort, for sincerity, and for her excellent presentation. I'm really grateful to Dr. Reshmi S. Kaimal, HOD, for her constant guidance and her support. Finally, a big thank you for all of you for attending the session, participating in discussion, for support, and for patient listening. Thank you, everyone.
Thank you all. Our next sessions will be announced soon, within 3 weeks in our group. Thank you, Emil sir, for joining us.
Okay, yeah, bye now.